Okay, so let's start off with talking about neurological emergencies. There are two basic concepts having to do with neurological emergencies that are important. One is, unfortunately, with the neurologic system, there is often an inverse relationship between the severity of the apparent neurologic symptom and the need to treat it emergently. And that sounds ridiculous, but the difficulty a lot of the times, and a lot of the problems that people have with neurologic symptoms, is that things can sound benign or sound subtle, and actually they are the precursor to more severe deficits, and that's why neurologic symptoms make people outside of neurology nervous. Is that you can't always tell how severe it is based on the severity of this how the symptoms sound. The second is the concept of familiarity breeding contempt. So that issue is that when you see something over and over again, you're comfortable with it. So the example that I use is my wife's an obstetrician, and she says, if your socks ain't squishing, it's just not that much blood. And so what happens is that there's a great tolerance for postpartum hemorrhage among obstetricians and gynecologists. And you're talking about young people, and they bleed a lot, and it's okay. And so what happens, because they're used to seeing a lot of bleeding from their postpartum patients, they tend to be relatively philosophical when they see it. And that's the case for all types of medicine. And that's definitely the case for neurology. So there are some very severe or apparently severe neurologic disorders that we have some that we are sort of philosophical about. Um, and it appears wrong, but really what happens is that sometimes the most severe looking neurologic issues are actually relatively benign, and probably the most common of those is seizures. So seizures look terrifying, but after you've seen a couple and you realize they're self-limited, you tend to have a more philosophical attitude about it, and you'll see that on the ward when you rotate on neurology. But uh, let's really just talk about neurologic emergencies. So what I'm going to do for each one of these cases is I'm going to read a clinical presentation of a common presentation of these disorders, and then talk a little bit about each one. So the first case is a 22-year-old man with a known seizure disorder. He presents to the emergency room. He was noted in the field to have a typical generalized tonic-clonic seizure. This lasted about 1 to 2 minutes. In the ambulance ride over, he has another generalized tonic-clonic seizure. In the ED, he has a third seizure. Each of the seizures is separated by about 20 minutes. He does not regain consciousness in between the events. So the issue with this case is not that the person had a generalized tonic-clonic seizure, which by itself is actually not that dangerous. It's the rapidity of the seizures without improvement of his mental status in between the seizures. And that's the definition of something called status epilepticus. It's defined as 2 or more seizures with failure to regain consciousness between the seizures. Some people define status epilepticus as a seizure that goes on for 30 minutes or more without regaining consciousness. Those are relatively rare, primarily because once you've been seizing that long, the chance of a good outcome is relatively low. It's much more common to have a seizure that goes on for 30 minutes and 45 minutes associated with simple partial or complex partial seizures, whereby you don't fall and shake, but you stare off into space, or you have a sensory aura or a visual aura. In general, status epilepticus, the neurologic emergency really is generalized tonic-clonic seizures, 2 or more without a failure to regain consciousness. So this is some first aid type of recommendations from the Epilepsy Foundation. And this may seem like a funny thing to teach medical students, but it is actually fairly important. And you see a lot of these rules being broken on the wards for a single seizure, so they are worth going over. So the first thing it says here is keep calm and reassure others who may be nearby, and that actually ends up being very important, because a single seizure by itself does not tend to be that dangerous for the most part. Don't hold the person down or try to stop his or her movements, and that's primarily because they'll injure you. Patients can be quite strong. You can hurt them and you can hurt yourself. You should just let the movements go. Time the seizure with your watch. That is an excellent thing to do. When you see someone having a seizure, it always appears to have gone on longer than you thought. Most seizures last about a minute or two. When you see someone have a seizure, you'll swear that it went on for 10 or 20 minutes or 30 minutes, when really it actually went on for a fairly short period of time. You do want to clear the area around a person to make sure there's nothing sharp or hard. You want to loosen any ties that might be around the neck. You want to try to put something soft and flat, like a folded jacket, underneath the head. You do want to turn him or her over gently onto one side. You do want to try to do that at the end of the seizure as the movements become more coarse. Primarily, the reason for this is that there's no airway movement when people are having a generalized tonic-clonic seizure, but there is a lot of activity, so the saliva will build up in the mouth. Once the seizure stops, they'll actually take they'll take an enormous in-breath, and whatever in the posterior pharynx will go right into the lungs. So you do want to turn them over on their side, so whatever in the mouth can sort of drain out the side of the mouth so they don't aspirate it. Don't try to force the mouth open with any hard implement, with your fingers, with a fork, and all that stuff you see in the movies is just wrong. A person having a seizure cannot swallow his tongue. If you remember from basic anatomy, it's actually attached in the front by the frenulum. There is no swallowing the tongue. What you can do is when people have their head flexed, the tongue can occlude the airway. And in order to open the airway, all you have to do is do a chin lift, whereby you pull the chin up a little bit, and it actually clears the airway quite nicely. But you can't swallow your tongue. Any effort to do anything with the teeth or jaws or tongue or anything like that will just injure you and the patient. Don't attempt artificial respirations unless the person hasn't started breathing afterwards. The problem is that when you're having a seizure, the diaphragm is in spasm, and you're not going to be able to get any air in anyway. So it's usually best just to wait for the seizure to dissipate. Stay with the person until the seizure ends naturally. Be friendly and reassuring afterwards, and that actually ends up being quite important, primarily because people are usually confused afterwards, and they'll often be agitated, and they can be, and if you're not sort of saying, "Oh, it's good to see you, please don't worry, everything's okay," and if they're surrounded by people, they can definitely get agitated. So how common are seizures in status epilepticus? About 10% of the population will experience a seizure at any one time. Acute symptomatic seizures represent about 40% of all seizures, that excluding febrile seizures in the pediatric population, and they have an incidence of about 29 to 39 per 100,000. The incidence of status epilepticus is actually much rarer. It's about 12.5 per 100,000. So seizures are relatively common. 10% of people will have a seizure at some time in their life. Status epilepticus is more uncommon. So what's the differential diagnosis for seizures or for status? Really, the issue is that there are three types of events. There are provoked seizures, there are unprovoked seizures, and there's the third type, which wasn't a seizure in the first place. Provoked seizures mean that you have someone and something has happened to them to trigger a seizure. So metabolic events can happen. Hypoglycemia is by far the most common cause of that. Infectious, like encephalitis or meningitis, or abscesses, traumatic. Somebody gets into a car accident and they have a post-event seizure, or trauma in terms of neurosurgical procedures. These are provoked seizures. Unprovoked seizures are often from genetic disorders or from baseline scars or tumors. So recurrent patients who have recurrent unprovoked seizures, that's the definition of epilepsy, right? So there's no reason for them to have this, or no clear reason, and they have recurrent seizure. That's epilepsy. The third thing was never a seizure in the first place. So the most common thing that was not seizure in the first place is syncope, people who pass out. Often when people pass out, they can have 10 seconds of sort of jerking activity as they fall. There's also a conversion disorder referred to as pseudoseizures, which is something that looks like seizures but is actually a psychiatric disorder. And it can be very difficult to separate pseudoseizures or non-electrical seizures from either provoked or unprovoked seizures. So the treatment of status epilepticus is as follows. So really you want to pay attention to the basics. You want to make sure the airway is open, that after they have their seizures, their breathing, heart rate and blood pressure, vitals are stable. You want to do a rapid assessment. You want to look for evidence of head trauma. You do want to try to get some history. You want to get some basic labs, especially a glucose, because you do not want to miss somebody who has hypoglycemia as a cause of their seizure or their status epilepticus, as all the anticonvulsants in the world won't help if they have a low glucose, and that's the reason for their alteration in status. You do want to think about a drug screen and a CT scan once the seizures are treated, and you want to get to the bottom of treating the seizure. So really the goal with status epilepticus is stop the seizure. The secondary goal is to find out what happened. There's always time to find out what happened, but really it's a neurologic emergency, so you want to move forward with treating the patient. And we tend to treat them, once you're sure that there's not hypoglycemia present, with anticonvulsants. So we typically start with lorazepam, which is a benzodiazepine. In adults, we'll start with 2 milligrams, going up to 8 milligrams over a short period of time. It's a total 0.1 milligram per kilogram dose when you're talking about children. We'll usually use phosphanytoin at the same time at 20 milligrams per kilogram, followed by a maintenance dose and levels. Really, if you haven't stopped the seizures after these two events, if they're still having seizures without improvement in mental status in between, we'll often move on to IV valproic acid or Depacon at 1,500 milligrams. And really, at that point, you don't want to delay anymore, and you want to move quickly on to general anesthesia. If you're failed 2 and 3 medications, it's really best not to dawdle and to move on to stopping the seizures. We will often use propofol or Versed just to turn the seizures off altogether. You do want to make sure the patient is intubated before you're starting those medications. It isn't absolutely necessary before that time, but when you start thinking about general anesthesia, they have to be intubated before that. You want to be careful about mixing your set of hypnotics without intubations electively. Patients on multiple medications who you're thinking about putting into a pharmacologic coma for status epilepticus really need EEG monitoring that's constant. So status epilepticus. So next clinical presentation. 28-year-old surgery resident, onset 3 days ago of tingling in his feet. He was seen in the ED, he was told he was okay, and he got sent home. He now returns and he's weaker. He's unable to stand on his heels and toes. He has problems climbing stairs. His neurologic exam is really not very notable except for some very mild distal weakness. His toes go down on his neurologic exam, but he really has no reflexes whatsoever at all. So this is a fairly classic presentation for something called Guillain-Barre. So Guillain-Barre is an acute to subacute demyelinating multifocal immune-mediated radicular neuropathy. So it is a demyelinating disorder that is immune-based. It will often start with numbness distally or multifocally. As it worsens, the sensory loss will sort of involve more of the limb, and then there's an ascending weakness. It can become so severe as to develop bifacial weakness as well as cranial nerve abnormalities. Really, the prototypic finding in the beginning is areflexia when you actually see nothing else. But it is an ascending paralysis. And as you can imagine, as the weakness ascends, there's more and more areas of the lower extremities and then arms and legs that become dysfunctional. And as it rises, the patients lose the ability to have spontaneous respiration. So it can be quite deadly when misdiagnosed or ignored. So Guillain-Barre occurs throughout the world with a median annual incidence of about 1.3 cases per 100,000. It's more prevalent in men and women aged from 15 to 35 and then again from 50 to 75. It occurs more commonly in the winter months, as the trigger for the demyelinating polyneuropathy is usually a viral illness. Sometimes it can be Campylobacter jejuni with diarrhea, but probably the most common trigger is a virus that has the same epitopes within the coating of the virus as the myelin sheaths, and so the immune system mistakes the myelin sheath for this virus or this bacteria, and it basically strips off its own myelin off the peripheral nerves, presenting with a rapidly progressive motor and sensory weakness in a length-dependent fashion. So the differential diagnosis, so Guillain-Barre can be mistaken for spinal cord tumors or masses, although we're going to talk about how you would tell the difference. Some type of spinal cord infections and hemorrhage. A rapidly progressive toxic neuropathy can look just like Guillain-Barre. The myopathies or inflammatory or toxic problems that affect the muscles can sometimes look like Guillain-Barre. Unfunctional disorders, people who just say they can't move their legs, they can't move, and it's actually with no solid neurologic findings can sometimes occur, although that is fairly uncommon and not the first thing you think of. So the diagnosis is made primarily through clinical exam, through a history that makes sense. A spinal fluid is often useful. You'll find elevated protein, but very few cells, and basically you get what is often referred to as a cytoalbuminologic dissociation. So very few cells, but a very high protein. And there will be abnormalities on EMG and nerve conduction studies, primarily because when you have demyelination, you have slowed saltatory conduction of motor and sensory nerves. You get these very slow conjunction velocities consistent with demyelination on EMG. So it can be a dangerous diagnosis. Failure to recognize this disorder can absolutely lead to death. If you see someone and they're having weakness in the legs and the weakness in the arms, and you think it's a spinal cord disorder, and you think it's something else, and you're working them up, and you're not properly identifying the cause, the rapid progression of the weakness can be quite significant. They can develop aspiration, they can develop respiratory failure. They can also have some of the most severe and profound autonomic instability in all of medicine. And that ends up being a major cause of death. They can have severe and sudden hypotension, cardiac arrhythmias. It can be quite impressive. That is more uncommon, but absolutely does happen in Guillain-Barre. So how do you manage this? So this sounds ridiculous, but I often say to the neurology residents that you cannot manage Guillain-Barre outside the hospital. If that is on your differential, they need to come into the hospital. So you always have to admit these people if you have a serious consideration of that disorder. I do tend to start with imaging of the spine, especially because sometimes a spinal cord compression Guillain-Barre can look similarly, especially because there's often spinal shock, which we'll talk about, but that is not unreasonable. We usually do a CBC, a SED rate. Lyme is one of the things that can trigger a Guillain-Barre like syndrome. Back in the day, new HIV seroconversion could present with Guillain-Barre also. Tox screen is indicated. And really probably the most important thing is to monitor something called vital capacity. So this is the amount that a patient can blow. Right? So most patients can if you take a deep breath, blow out about 15 to 20 cc's per kilogram, and that can be measured. As they get weaker and weaker, they're unable to force out as much air because they get weakness of the diaphragm and weakness of the intercostal muscles. And as that number begins to fall, you know that they're actually getting weaker and that they may have to be electively intubated. It is very important to consider DVT prophylaxis in any person who's no longer able to walk, because that is DVT and P is a fairly significant cause of morbidity and mortality. It tends to be treated with IVIG or plasma exchange, and both of these interventions either deactivate, downregulate, or frankly remove the abnormal immunoglobulins that are in the system. All right, next case. A 64-year-old man with hypertension and hypercholesterolemia. His wife brings him in after the acute onset of left-sided weakness, hemiplegia, which just means left-sided weakness. Hemiparesis means just a little bit of weakness. Plegia means, very weak. Dysarthria. His blood pressure is 190 over 115 with a pulse of 90. So, an ischemic stroke is defined as following. So, an acute interruption of blood flow to the brain, cerebellum, brainstem, or spinal cord. primarily arterial occlusion secondary to thrombosis, embolization, venous occlusion, or parenchymal bleeding within the CNS, causing an acute neurologic symptom, right? So a stroke is not quite enough blood going to the brain or to the brainstem or to the cerebellum or to the spinal cord all of a sudden. And that can be because of thrombosis of the vessel. It can be because of embolization. And it can also be secondary to hemorrhage, and that actually causes ischemia. So epidemiology. So the important thing about stroke is that it is the number 5 cause of death in the United States. It is not a rare disorder. It is still the number 1 cause of disability. Every year, more than almost 800,000 people in the United States have a stroke. In 2009, 34% of the hospitalized patients people were hospitalized for stroke were younger than the age of 65. And stroke at the ages between 20 and 44 is on the rise, and there is all sorts of reasons for that. So this is not just a disorder of little old people. This can be a disorder of young women, of young men, depending on all sorts of other factors. So it is a very important neurologic issue to understand. So there is a fairly wide differential diagnosis of the type of stroke. So I think that you can have a hemorrhagic stroke, which is basically bleeding into the brain, which causes ischemia secondarily to compression of the local vessels. Ischemic stroke means that not enough blood is going to the brain because of an occlusion of the arterial system for one reason or another. And intracranial hemorrhage is basically a subdural or an epidural hematoma. Those usually cause less stroke symptoms and cause more alteration of the mental status, but they can be focality. And encephalitis, an infection of the brain. Seizures can look just like strokes in the beginning, especially if you have a seizure focus on one side and you begin having a seizure involving one side. When the person recovers, they'll often be weak on that side. It's referred to as a Todd's paralysis. And it can be very difficult to sort out whether someone has a Todd's paralysis or a new stroke if you're missing that history that there was a recent seizure. And then obviously trauma can, especially to the brain or spinal cord, can present with a hemiparesis. It can look like strokes in the beginning. So in general, the evaluation for new stroke is always airway, breathing, circulation. And EKG is very useful because there are certain heart rhythms like atrial fibrillation that predispose you to embolic infarcts. You do want to get a prompt CT scan. That ends up being very important because you do want to separate a hemorrhagic stroke from an ischemic stroke. You want to make sure there is not any evidence of intracranial hemorrhage. You do want to look for evidence of trauma. Basic bloods are quite important. We end up doing an NA stroke scale, which is a measurement of severity fairly early. And in those people who have not had a stroke going on for very long, who have significant deficits that were clear by history and by examination that there's a stroke, we do often give intravenous TPA and sometimes follow that with mechanical thrombectomy once there's confirmation of an arterial occlusion. So these are something that you'll absolutely see when you're in neurology, and we move fast and work them up quickly and try to treat as many as we can with thrombolytic agents. So the important thing about stroke is that it's a clinical diagnosis, right? So you do it by history and by physical and by the neurologic exam. And here is just some examples. So the thing about the patient in A and in B is both of these people are having enormous strokes. They're actually having very large strokes, and the CAT scan is normal. So the problem is that especially on CT imaging, the imaging will be normal for hours, actually. So what happens is that's one of the reasons why the neurologic exam and the history is so important. So in order for us to give intravenous TPA, we really have to have a good history, have a good examination, be convinced of the diagnosis, and you only get that through rapidity and seeing them over and over again. So what you can see is the patient in A is the same as the patient in C. Patient in B is the same as the patient in D. So in A, there's not much of a stroke. Maybe there's some early findings, but if you come down to C, this is where the person ended up having a stroke. When you look at patient B, this actually looks fairly good, but this is where the person ended up having a stroke. So CAT scans will be normal for the first day. So we don't tend to wait around for the CAT scan to tell us what's going on for the most part. In general, MR is much better at showing us acute strokes, So you'll often see when we think somebody has a small stroke, we want to know right away whether that's the issue. We'll order MR more in the beginning. But when you're talking about acute thrombolysis, at both campuses, we tend to start off with a CT scan. So the thing about TPA is it's a good medicine and it works, but when someone's having a stroke, there are some potential downsides. Primarily, it's the issue of reperfusion. So you have someone, they have an occluded vessel, it's been going on for an hour, maybe an hour and a half, and when you open up that artery, you have blood that goes back into this abnormal area, and you can have hemorrhagic transformation of ischemic stroke. Really, the way we try to limit that is to select our patients well. Right? So there are some significant exclusions to TPA, and those exclusions are in place because when these are present, there's a higher rate of bleeding. So examples of TPA exclusions for acute stroke would be unable to decrease a very high blood pressure, greater than 185 systolic, really someone who's had surgery within the last 2 weeks that predispose you to bleeding that you may not be able to control. Primarily when you give tissue plasminogen activator, it opens up all of the clots that you have. So if you've had recent surgery, those will start bleeding again. Someone who's had a recent stroke, and that's within the last several months, you don't want to have reperfusion and bleed into that. Someone who is already anticoagulated. People who have onset of their deficits with a seizure, and that's primarily so you're not giving TPA to people with a Todd's paralysis who actually may have weakness because of seizure. That is a relative contraindication. You definitely can have both at the same time, but you do have to be careful and wonder when someone comes in with acute deficit whether this is a postictal Todd's or whether this is ischemic stroke. People who have rapidly clearing and minimal deficits, that is something that stroke neurologists will sometimes fight about, but it is one of the exclusions. Any type of bleeding, diathesis, brain hemorrhage, or tumor ends up being a relative contraindication, especially depending on the size of the tumor, location, and whether it has at baseline a hemorrhagic component to it. All right, so next neurologic emergency. A 72-year-old man with non-Hodgkin's lymphoma complains of mild gait disturbance and urinary urge incontinence. His arms are fine, but when you examine his legs, there is 4 out of 5 power. His reflexes show hyperactivity in the lower extremities and upgoing toes. There is sensory loss to the belly button bilaterally. So this is an example of someone who says, yeah, I'm not walking so well, and there's been a change in my urination. And this is an example of someone who's got a very bad neurologic problem where the chief complaint is actually relatively mild. And it's only the examination when you do it that shows you that there's actually an ongoing and concerning issue. So this is a fairly prototypic presentation of a spinal cord compression. So compression of the spinal cord basically is from a tumor or blood or normal structures, bone or infection, where there's compression of the normal spinal cord and there's dysfunction that's referable to that crushing injury. So spinal cord injury occurs throughout many countries in the world and has an annual incidence of about 15 to 40 cases per million. Once discovered, the patient is often left to manage the effects over the entire lifetime. So an early diagnosis really seeks to limit the amount of spinal cord injury. So in a lot of ways, spinal cord is different than Guillain-Barre or stroke or any of the other things we've talked about. When you miss spinal cord dysfunction, they are left with those deficits forever. So it's very important to pick it up early and to treat aggressively, because what happens is that the patients will often be left with whatever deficits they have at the point in time that you make the correct diagnosis and localization. So what's the differential diagnosis of spinal cord dysfunction? Well, there are several things. One is, sometimes you can just have, disuse. Sometimes people can be in bed and not get up and not move around. They can have weakness everywhere. It can look like a spinal cord dysfunction, but they have downgoing toes. They don't have increased reflexes, and that moves you away from a spinal cord dysfunction. Amyotrophic lateral sclerosis, Lou Gehrig's disease, can look like certain types of spinal cord dysfunction. And it is something that you want to consider when you're considering that diagnosis, especially if it's been going on over time. Some severe neuropathies can look like a spinal cord dysfunction, especially Guillain-Barre, especially if you have sort of a sensory level of the abdomen and you can't move the legs on either side. There's often some consideration of whether this is a nerve problem or this is a spinal cord problem, although really on examination you should be able to clearly differentiate those. Tumors, trauma, infections are all things that can affect the spinal cord, cause compression and cause dysfunction that need to be treated fairly aggressively. So in general, the presentation details they can be rapid and they can be slowly progression of weakness following along a spinal motor homunculus. Now what that means is that the way the motor homunculus in the spinal cord works is that the arms and shoulders are in the midline, and so is the head, and the back and the posterior is lateral of the spinal cord. So when you push on the lateral aspect of the spinal cord, just a little bit, anywhere in the spinal cord, like in the neck, what you'll get first is bowel and bladder dysfunction. And then as you push a little bit more, you'll have leg weakness. And so people will say, oh, they have bowel bladder incontinence, they have leg weakness, the spinal cord dysfunction must be way low in the spinal cord. But really, that's not true. If you have extrinsic compression anywhere in the spinal cord, then the first symptoms will almost always be bowel and bladder and leg weakness. So those are what we refer to as non-localizing signs. Really, and the other important thing is the failure to act promptly really can result in paraplegia or worse. And so it is important to think about it, to do your examination and image quickly when it's being considered. Really, one of the important keys is that a reduced rectal tone is not seen in Guillain-Barre, is not seen in most of the neuropathies. And when you see that, you really need to think about a spinal cord dysfunction. The other issue is upper motor neuron weakness in the lower extremities. And what I mean is increased tone, increased reflexes, upgoing toes. You're never going to see that in a neuropathy like Guillain-Barre, right? So those are signs of an upper motor neuron process, which makes this more spinal cord. People who have a lower motor neuron process will have downgoing toes and dropped reflexes. So reflexes and toes are not just for fun. It's not just things that we make people do so that we can say they've done a good exam. They actually have a very important important role in figuring out where the disorder is when you have people who have paraplegia. So once that's being considered, you do want to get prompt imaging. We tend to use spinal MRI when you're considering spinal cord compression. We often will treat with steroids or surgical decompression depending on the etiology once it's discovered. So the important things about spinal cord compression is a key to diagnosis is a sensory level, right? So there's almost nothing that gives you, I can't feel anything below my belly button on both sides besides spinal cord dysfunction. Sometimes a neuropathy can do it, sometimes Guillain-Barre can do it, but really when you have, I can't feel anything below my nipples, I can't feel anything at a sensory level, you want to think carefully about a spinal cord compression. Remember that the sensory level is often lower than the level of compression. If someone can't feel anything at the belly button, it does not mean that that's where the compression is. That is the lowest level possible of the compression. Not being able to feel anything below the belly button and to the legs means that the problem is between C1 and all the way at the belly button. That means the lowest level, not the highest level. Really, motor levels are actually much more sensitive, but that's beyond this conversation. A rectal examination is very important to look for decreased tone. A reflex examination might show you diminished reflexes at the level of the compression and increased reflexes below. So if you had a tumor at, God forbid you had a tumor at C6 compressing the spinal cord, maybe your legs wouldn't work, maybe you couldn't feel the legs, maybe you had a sensory level at the mid-abdomen. If you hit the reflexes at the biceps, there may be dropped reflexes, and if you hit it at the triceps, which is lower, there may be increased reflexes. So dropped reflexes at the site of compression is one of those things, with increased reflexes below that is actually a very good localizing sign. And they will often have upgoing toes because it is an upper motor neuron process. So this is an MRI, and what you can see is to the left is the front and to the back is the right. What you can see is dark spinal cord and you can see vertebrae. Basically, this where the red arrows are the level of spinal cord compression, and what you can see is there's white CSF around the spinal cord above it, but really at the level of compression, there's no spinal cord around it, and you can see the spinal cord is being crushed quite effectively there. Now, what's interesting is this patient presented just with bilateral lower extremity numbness and weakness, even though this is a compression at C5, C6, and you might expect them to be numb from the shoulders down. But don't forget, when you have compression, it is the lower extremities that get affected first, and this is a nice example of that. So in cord compression, there has been for many years a pattern of treating with high-dose dexamethasone or 100 milligrams. This is really falling out of favor with trauma. It's not really been shown to be that helpful, and it's falling out of favor. We will still use steroids when you're talking about spinal cord compression from tumors, which can cause edema. But really, the best treatment is acute neurosurgical and or orthopedic consultation and irradiation decompression in those types of lesions that are amenable to those. All right, next case. A 45-year-old woman complains of double vision, lid droop. She may have some problems swallowing as the day goes on. And then when you examine her muscle strength actually feels fairly normal, and the reflexes are normal. So the definition of myasthenia gravis, which is what this is a case of, is weakness of the cranial nerves and proximal muscles due to an autoimmune blockade at the neuromuscular junction. So the epidemiology of myasthenia gravis is the prevalence of myasthenia in the U.S. is about 14 to 20 per 100,000. There are about 36 to 60 cases in the United States at any one time. Myasthenia gravis is probably underdiagnosed, and the prevalence is actually probably much higher, and that's definitely the case. There are lots of patients with subtle myasthenia where it will become triggered through the use of certain medications, or there's sort of a waxing and waning pattern to myasthenia often. Women are more affected than men. In the differential diagnosis for myasthenia is there's a rarer syndrome called Lambert-Eaton syndrome that can look a lot like myasthenia gravis, which is a similar type of autoimmune disorder. Hypokalemic periodic paralysis. Sometimes people with low potassium can develop periodic paralysis and weakness that is intermittent. So you see them at 1 minute and they're weak, and you see them slightly later and they're fine, and there's some fatigability of their muscle system. Sometimes brainstem inflammation or infection can affect the cranial nerves and can present with cranial nerve-only abnormalities and fatigue. Brainstem strokes are often mistaken for myasthenia and vice versa, especially when it's acute because of the involvement of the cranial nerves. Some types of myopathies can give you proximal muscle weakness and cranial nerve weakness that fluctuates. The brainstem encephalitis can often affect the cranial nerves also. So myasthenia may progress rapidly and impair swallowing and respiration. They'll often have normal strength, but fatigue is prominent. Now, I'm not talking about fatigue like, doc, I'm so tired, I'm tired all the time, that type of fatigue. Neurologic fatigue is you have them do an action, and they do it normally with full strength, and then the more you repeat that action, the less able they are to do it. So an example would be you have someone put their arm out in front of them, and you push down, and they're able to do it well, and then you push down again, and it's a little weaker, and you push down again, and it's a little weaker, and after you've done it 5 or 6 times, they aren't able to lift the arm up any longer. Or classically with myasthenia, people will say, I can speak and I can speak normally, but the more that I speak, the more I have problems controlling my jaw, till after I've spoken for 5 or 6 minutes, I can't close my jaw at all. That's what fatigue means. The more I use a muscle, the weaker it gets. That's really what neurologic fatigue is. And fatigue is really the prototypic symptom of myasthenia gravis. So it typically begins with eye movement abnormalities, especially double vision at end gaze in a prolonged fashion. So if someone looks up or down or to the left for an extended period of time, they begin to see double, although they didn't see double in the beginning. There can be bulbar weakness, primarily dysarthria and dysphagia, and the more they speak and the more they swallow, the weaker it gets. There can be some proximal greater than distal weakness in addition. So it is primarily diagnosed with repetitive muscle testing. So there isn't much, Lambert-Eaton syndrome can do it, but there isn't much that gives you the disorders that give you normal strength, 100% normal, and the more you use it, the weaker they get. There is an antibody test to the ACH receptor antibody that's actually quite sensitive and specific. We'll often do CT scans of the chest looking for tumors of the thymus gland. And so this is just a little picture of the issue. So number 1 is the presynaptic terminal. Number 2 is the postsynaptic sarcolemma. 3 is the synaptic vesicles. 4 is the ACH antibodies, and 5 is mitochondria. And what happens is that when you have myasthenia gravis, there are antibodies to the number 4, to the ACH receptors, to the receptor. To those receptors. So you basically have an autoimmune reaction against those postsynaptic receptors. So when acetylcholine is flooded into the system, because only a population of those receptors are dysfunctional, it works fine the first time, but each one of those receptors needs time to reboot, right? So what happens, you do one activity and it works okay, you do the next activity, and because the population has been reduced by ACH as well as the antibodies, the number of active receptors is lower. So each time you activate, there's less and less receptors that are ready to receive ACH, and so you get weaker and weaker and weaker. And it's because a certain population of the postsynaptic receptors are being deactivated by this immunoglobulin. So the treatment ends up being a medicine called pyridostigmine or mestinon, which enhances it enhances synaptic transmission at the neuromuscular end plate. We'll often use prednisone or azathioprine and cyclosporin, which reduce the effectiveness of the immune system so that the body produces less immunoglobulin against its own postsynaptic receptors. We'll use plasma exchange as well as IVIG also, which reduce the amount of immunoglobulins against the postsynaptic receptors. Thymectomy is often sometimes helpful. All right, so next case. This is a 78-year-old woman with a history of some headaches as a young woman who develops the acute severe headache and vomiting. Her pupils show a slightly larger pupil noticed by the nurse. You find the pupils are poorly reactive. She's sleepy and then confused, agitated and poorly responsive. She has a mild stiff neck. She has preretinal hemorrhages on fundoscopic exam. So in this case, this is a presentation of a subarachnoid hemorrhage. Subarachnoid hemorrhage is bleeding within the subarachnoid space and not necessarily directly acting on compression of the brain parenchyma. So a subarachnoid hemorrhage is bleeding in the subarachnoid space, which is around the brain and around the brainstem and around the cranial nerves. It's typically from rupture of an aneurysm or AVM or trauma. The incidence of subarachnoid hemorrhage is about 9 per 100,000. Young people are much less likely than middle-aged people to have subarachnoid hemorrhage. It is even when recognized, it is a very dangerous disorder. So the mortality can be upwards of 50% even when recognized. And unfortunately, we see patients with subarachnoid hemorrhage on the neurosurgery service with an acute rupture where we know what it is, we treat them effectively, and they still do poorly. It is a very dangerous disorder. So really, when you see subarachnoid hemorrhage, the attention to basics is the most important. You look at airway, you look at vital signs. You're going to treat any severe hypertension. That you want to put the head of bed up at 30 degrees to enhance venous blood flow out of the brain. We'll often use nibodipine after admission to reduce the chance of vasospasm. So the difficulty is the blood is irritable to the blood vessels and can cause vasospasm and clamping down of the blood vessels. Before the aneurysm is treated, we do absolute bed rest, avoid any type of Valsalva, avoid any constipation. Primarily when there's a sentinel hemorrhage, when there's a little bit of a hemorrhage and the aneurysm heals, you don't want it to re-rupture and it's the re-rupturing that causes a lot of difficulty. So when there's an acute onset of subarachnoid hemorrhage with rapid improvement of the symptoms, this is sometimes the most dangerous period, even though they're getting a little better. The aneurysm needs to be secured for the most part. In general, the way we secure aneurysms is either by clipping, which was first done by Dandy here at Johns Hopkins, or by coiling the aneurysms. Once the aneurysm is controlled, then the management of the vasospasm and the other issues having to do with the neurologic dysfunction can move forward. But really, until the aneurysm is controlled or stopped from bleeding, it is a very unstable situation. So this is a typical CT of someone with a very bad subarachnoid hemorrhage. And so what you can see is you can see white bone and the sort of dark gray brain, and there's sort of all this white within the sort of nooks and crannies of the brain. And this is blood layering out within the subarachnoid space. What you can see is the occipital horns of the temporal horns of the ventricles are enlarged, and that's because there's a decreased ability of CSF to drain out, and the pressure within the brain is actually building because CSF cannot normally circulate out of the brain, and pressure is increasing. So this is a very bad situation. This is subarachnoid hemorrhage. Can present just with the worst headache of your life and then progressive lethargy. Okay. Here's another headache case. So a 28-year-old woman presents having just delivered a child. She is developing vomiting and dehydration. She has a severe headache. She has double vision. She's had at least one seizure, and then on examination she has papilledema. And papilledema is basically you look in the back of the eyes, and the optic disc, instead of being flat behind the eye, is actually pushing out into the vitreous, and it is a sign of increased intracranial pressure. So this is a presentation of a dural sinus occlusion. So an occlusion of one of the dural sinuses is usually due to clot within the venous sinuses, and this causes a backup of pressure. The blood can't leave the cranial vault, and so with each heartbeat, more arterial blood enters the brain, but because the venous system is compromised, the pressure can't flow out of the brain along the venous system, and it causes increasing intracranial pressure. Basically, the pathophysiology is that it's a clot within the venous system, so it's exactly like a DVT, a deep venous thrombosis. The difficulty with a dural sinus occlusion is that the worst part of it is not PE or pulmonary embolus. The worst part is the actual swelling of the brain that occurs. So when you have a DVT in your leg, you'll see patients, their leg will get bigger and bigger and bigger, and that's a problem, but it's not the end of the world because the skin can expand. The difficulty in the brain is there's no space for the brain to expand when it swells, and it can cause very severe damage. It presents with the classic triad of seizures, papilledema, and headache. So the epidemiology is about 11 per 100,000 mothers with an uncomplicated delivery. It's about 1 to 2 out of every 100,000 for all others. It really occurs most often with systemic hypercoagulable states, with volume depletion and cancer. Volume depletion actually ends up being fairly important. When you have very, very severe volume depletion, you're predisposing to venous clots, and the dural sinus occlusions definitely can happen also. Atypical infections that occur within the facial region, within something called the danger area, can also lead to a dural sinus occlusion secondary to local infection. So the danger area is that area right around your nose, sort of under your eyes, to the side and to the bottom of the top lip, and so to your cheekbones on the left and right. And infections in this area, surgery in this area, can, when there's an infection, it drains back into the cavernous sinus and then secondarily into the sagittal sinuses. And clots and infections in this region can reach this danger area and predispose you to clots and infections within the dural sinus. And so what we have here is that we have a couple of scans. So on the first level, you see there's basically cuts of the brain with some little white arrows next to them, and they're pointing to some very subtle areas, and those are venous infarcts. On the second level, on the right, what you see is a dark gray brain, and it looks like there's a sagittal sinus and an inferior sagittal sinus, and the white arrows are pointing to where there's not good flow within the superior sagittal sinus. That's clot within that region. On the next one down is an angiogram, and really where the white arrows are show you where there should be venous flow, and there's actually no venous flow whatsoever due to clot in that region. The last one is the first patient, and what happens when you clear the clot is you can see that the subtle area that was in the white arrows is gone, and the last scan to the right shows you what the sagittal sinus is supposed to look like and looked like initially, and that's compared to figure 4 where the sagittal sinus is absent. So dural sinus thrombosis present with headache and papilledema, focal findings, alteration of consciousness, seizures in the setting of a hypercoagulable state, and the postpartum period is a well-known hypercoagulable state, and so that can happen. The key is to early recognition, for the symptoms and signs that we talked about, looking for dehydration and high dose contraceptive use, pregnancy, and really the treatment is heparin, just like in DVT. You want to use heparin to help dissolve the venous clot and restore good blood outflow of the brain again. All right, so this is just a few interesting neurologic emergencies that you'll see on neurology. These are probably the most serious ones. You'll see lots of things besides this, but these are the ones to sort of be aware of that we see and that we worry a lot about when they present in such a manner. All right, thank you so much.